Okay. Assalamu alaikum. Hello, everyone. Good afternoon or good evening is your time. Under the patronage of Professor Wagdi Talat, President of Egyptian Society for Medical Education, we, Training Committee, welcome you all to our monthly webinar. I'm Dr. Hala Agina, Professor of Pathology, Faculty of Medicine, Banha University, and Coordinator of Training Committee of Egyptian Society for Medical Education. I'm truly excited to be your host for today's session in collaboration with Professor Mariam Asad. In the ever-evolving landscape of medical education, the integration of innovative teaching methods has become imperative. So today's our webinar is titled Exploring Simulation-Based Medical Education, an insight into innovative learning methods. Before we dive into this exciting topic, let me introduce our distinguished speakers. Firstly, we are honored to have Professor Japin Fayaz. She is SimKids Medical Director. She is the resuscitation lead for the competency-based medical education program. Her interest is exploring simulation as system and process testing and providing an enriching cultural environment in teaching and learning. She's an active member of the Simulation Steering Committee since 2019. She's visiting faculty in Pakistan and Indian University. Our second speaker is Professor Dr. Muhammad Al-Hadi, Mahmoud Al-Qasim. He's a medical education specialist, emergency medicine specialist doctor. His previous clinical skills instructor, communication and physical diagnosing course director at St. George University, 2015 to 2018. We look forward to gaining valuable perspective from them and share their expertise with us. So let's start with Professor Dr. Japin.
Hello, everyone. Assalamu alaikum. And I am very excited to be here with all the valuable and experienced learners, educators, professors here. And I always say in such quorum that it's me who will be sharing my knowledge, but then in return, I'm learning so much from all of you because I have like here 28 plus participants. So thank you so much for giving us this, me and Muhammad, this opportunity. I am, from my clinical background, pediatric emergency medicine staff physician at the Hospital for Sick Children, Toronto, Canada. And I have been involved in simulation-based education for last 7 years. And I have done my simulation fellowship followed by PhD in simulation from MGH IHP, which is an Harvard affiliate, just last year. So I'm just so glad that we are here talking about utilization of simulation in the curriculums. And then I have to say that today we are going to talk about some introduction of the various higher level concept. We are not going to go in detail. We just want to give you a flavor what a simulation based education is and what are some of the concepts are. And as I always say in such forums, that this is the start of our relationship. We are building this community of practice together. So this will not end by today's webinar. We are just starting together and we will continue to learn, interact, do workshops together. With this, I will pass it on to Muhammad to say a couple of words while I'm sharing my presentation to start. Muhammad, over to you.
Assalamu alaikum, everyone, and good evening. It's my pleasure to be with you today. I have known Dr. Japin for the last 4 years. We have been working together in these simulation activities. we had never had a chance to meet face to face up to the moment, although we have been doing lots of projects together. It's my pleasure and my ownership to be with you today, hoping to learn from you and share our experience with you.
Thank you so much, Mohammed. So what our plan today is to talk about why simulation and some of the terminologies of simulation. Then I will hand it over to Mohammed to talk about some elements of scenario design and scenario development, followed by how to facilitate a simulation session. And then I will come back at the end to talk about a little bit about debriefing. Please feel free to interact. I do not want to make it a one-way conversation. You all are more than welcome to continue participating by putting your thoughts in the chat. I will keep an eye. I will be looking at one side. I'm not ignoring anyone. It is just another computer for looking at the chat. So that's why you will see me intermittently looking at the side. Also, again, we have created a WhatsApp group as well. That is also like, as we will be providing a lots of concepts here. When you are reflecting, there might be some of the queries, comments, question will come up. So please feel free to ask us on the WhatsApp group. And also we will be sharing resources after our presentation on the WhatsApp group as well, so that you will continue consulting with those resources and learning from them. Today's the first presentation learning objectives will be just to define simulation, some examples of simulation and advantages of using simulation, and then some of the basic learning theories which support the simulation-based learning. This is the picture of our sim center with our sim team, which you can see. And this is our new sim building, like a new patient support building. In the down floor, we have a sim center, and you are more than, any one of you are more than welcome when you are visiting, or if you are visiting Toronto, let me know. I will be happy to organize a sim center visit for you, along with any few days observation if you want to have. I do not have any disclosure or conflict of interest. Coming to our first question, that what is simulation? Often we hear that it requires, simulation is a educational pedagogy or a way of educating people. We all know our learners, and we know that it is the voice of the era. Everybody talk about simulation. It sounds very fascinating, but then we also have this concept that it requires expensive equipment or mannequins. Some will probably say that simulations are drill or the use of task trainer just to practice some skills, for example, intubation, IV insertion. But it is like, if I would like to define simulation, which is by Gaba Diem, who is considered as a father of simulation. So I would emphasize that simulation is a technique, not a technology. What we get more kind of entangled in the concept that simulation is all about technology. No, simulation is another kind of technique, like competency-based education, like PBL. So again, simulation is a technique, not the technology, to replace or amplify real experiences with guided experiences that evoke or replicate substantial aspect of the real life in a fully interactive manner. And how to explain you, when I was a medical student or when I was a resident, I did my residency in pediatric medicine, how I learned intubation. Like, unfortunately, when some patient is either dying or died, our seniors used to tell us, this is a moment for you to practice intubation because it provides the most realism. How we learn about passing IV cannula just to practice on patients. But do you all think that this is the right way to learn? Or as a learner, it is a safe environment for me to learn on an actual patient with a lot of stress, with a lot of anxiety ongoing? No. So that is how the simulation evolve into a technique or pedagogy, that there should be some better ways of making your learner to learn or to practice some of these techniques. So coming to some common terms. First of all, mannequins. what are the mannequins? Like any ideas from the team, like any thoughts, please continue to put in the chat. And because of the like time purpose, so mannequins are simply a life-size human-like simulator representing a patient for healthcare simulation and education. It can be very, very basic mannequin, and it doesn't need to be a full body mannequin. It can be full or partial body representation of a patient for practice. For example, for airway practice, you do not need a full mannequin. A mannequin like this, which is called airway task trainer, is all enough. Okay, so it doesn't need to make sounds, talk to you. It can be a very, very simple, like a human-like simulator, which represent a human body. Then come to the task trainer. Task trainers are the items or are the various designed mannequins which are designed to practice and do repetition of the clinical skills. For example, IV task trainer, chest tube task trainer, airway task trainer. So for a suturing task trainer, as you can see here, you just need a pad of a plastic material where you can practice the suturing. I used to practice on the orange peels. So that was my very low fidelity task trainer. So task trainer again does not need to be made up of plastic. We are now doing a lot of task trainer which are made up of 3D printing plastic material. So task trainer can be made up of anything, but the basic purpose of task trainer is to practice a skill and continue to practice it till you achieve a competence or a mastery. Then it comes a simulated participant or hybrid. Simulated participants are the same as simulated patient, but for simulation, in simulation language, we do not like the preferred terminology for simulation patient is simulated participant, because a lot of them are not patient. They are only portraying themselves as some sign and symptoms which patients will provide. So it is a simulated participant. And there are some terminologies which is used that is called simulated person. Simulated person is a person who portrays a patient, family member, or a healthcare provider in order to meet the objectives of the simulation. So that is the terminology which is used for a simulated person, and that can be called as a simulated participant as well. We all are now hearing a boom of virtual, augmented, and mixed reality. So what are these? So if we look at some of the definition, and Leo C.L. Is an author of the Healthcare Simulation Dictionary, which I will be showing the link to it and sharing in the WhatsApp group. And all these definitions of terminologies are present in Healthcare Simulation Dictionary, which is vital for every sim educator to have. Like me and Mohammed has it on our desktop, because every time our terminology come into our notice, we always see what does it mean, because it is very important to have a uniform common language so that we know what we are saying is being communicated in the same way. So if we look at the virtual reality, so virtual reality is the use of computer technology to create an interactive three-dimensional world in which the object have a sense of spatial presence. Virtual environment and virtual worlds are synonyms for virtual reality, which is being used. The virtual reality is thought to be very costly because it takes tons of effort. So now it comes a mixed reality. What is the mixed reality? Mixed reality is on the top of your mannequin, which is already existing mannequin, you will add on a layer of computer technology. So mixed reality is a category that encompasses the hybrid combination of virtual reality environment and the real environment. which include the standardized patient, standardized participants, normal mannequin simulator. And one of the example is what we have done. Like, for example, we have to show people to do X-ray. They ask for X-ray or auscultation. What we did, we put a barcode of the auscultation audios on underneath the skin of the mannequin. And when they put a stethoscope, we will play the video or audio will play on their cell phones or on the available iPad. And that become a mixed reality, that they are hearing the sound from the iPad or from the phone of somebody who can have this barcode scan. Or another example is the ultrasound images. When a trauma patient come in and they have to do a trauma point of care ultrasound, and they have to see the images and interpret the images while they are doing a trauma scenario. So what we did, we put a right upper quadrant, left upper quadrant, and for the cardiac focus in the sternal area, some barcodes. And as soon as they put the probe near those areas, the videos start to play on the screen, which is present in front, and they can see the image of their ultrasound wherever they have put their probe, if it is placed on the right place. So this is called mixed reality, where we are combining computer technology with your real environment. The benefit of mixed reality is it is low cost in comparison to the virtual reality, and it will provide the similar kind of feel and information to the learner, which the virtual reality is supposed to provide. The other concept which is coming up a lot is the game-based simulation. Game-based simulations are goal-oriented and rule-based event. You cannot teach like game-based simulation or computer-based scenarios. So it is usually good for those scenarios which are very algorithmic. For example, pediatric advanced life support, neonatal resuscitation, where they have only one pathway and it's not a lot of controversy is there. So people will get engaged in those computer-based scenarios, and they will choose their own journey while go through the computer-based learning. So there's a lot of game-based simulations which are coming up in the market. And Mohammed is talking about how to utilize the AI in simulation-based learning. And some of the game-based simulations are using AI in the back end as well. So you will see a lot in the market in the coming years. Now I will shift gears from the different definition of different terminologies, that how would you decide what type of simulation you are going to choose? It is a very, very important decision because a lot of cost is available. You have to choose the right learners. You have to choose the right key stakeholders and partners. And then the resources is never ever unlimited. You have to reassign the resources because somebody has to pay for those resources, and the faculty development and faculty training and time as well. That is why it is very, very important to choose the right type of simulation. So some of the questions that you have to ask yourself when you are in the planning phase, that what kind of simulation I'm going to choose. So these are some of the questions which are well described in the literature, that what is the expected learning outcome? Does the simulation best matches the objective? For example, if I am choosing a virtual reality to teach intubation, does it make sense that it will make my learner competent in intubation? Because virtual reality, you are just in a learning environment and you are just seeing and interacting with a virtual environment. They are not able to learn the skill best. Yes, for task trainer will be the best type of simulation for teaching intubation. Similarly, communication. You cannot teach communication in a high acuity kind of big sim lab with a high technology mannequin who can speak, who can talk, because it can never give you a feel of a person two-person communicating. So for that type of simulation, a simulated participant is the best pedagogy to choose. So that is why it is very important to have your expected learning outcome. Is the simulation matches your objective? Do I need to immerse the learner, or will they practice discrete skill? Immerse the learner mean, am I teaching them how to work as a team to manage a patient who is coming in cardiac arrest? So here a lot of like nurses, physician, respiratory therapist has to interact and work as a team, versus just need to break the bad news. So it is a discrete practice, or they have to just learn about intubation. So you have to think about it. Am I going to make the learner learn in the team, or they are going to practice only single-handed? What levels are my learner? What are they capable of? How close to reality does the simulation need to be? Choose what best support the learning objective, learners, and available resources. Aim high, but then think and scan your own environment. So these are some of the aspects that you have to keep in mind as educators when you are planning a simulation-based activity. Then a very, very important concept of fidelity. Fidelity is often misinterpreted as technology. We all, like even me as educator, have a concept that fidelity means technology. I can only have a high fidelity simulation if I have multi-$1,000 mannequins who can blink, who can speak, who can answer me, or who can make movements. No, it is not true. The fidelity is the level of realism associated with a particular simulation activity, and fidelity has many dimensions. For example, if I ask you a question, all of you, will you think doing in the actual clinic or actual emergency room event of cardiac arrest will be most real, or doing it in a sim, it will be more real? Which will give you the participants a real environment? Doing it in the resuscitation room, where all the actual practicing physician and nurses with all the actual available equipment are managing a cardiac arrest patient, versus doing in a sim with all the sim gadgets? Which one will be more real? Any thoughts? ER, yes, perfect. So the ER room one, although if I'm using just a doll or helping breathing baby small mannequin, which is just the head and the torso of the baby, if I'm using even that low cost mannequin, it will still be a high fidelity, because it is providing the highest level of realism to my learner and to my participants. It will be low technology, but high realism. So the fidelity will be high. So this is very, very important to understand, that fidelity is directly proportional to the level of realism. And realism has got physical factors, psychological factor, and social factor. Some of the examples of physical factor is environment, equipment, and related tool. Psychological factors are, am I able to provoke the same kind of emotion, beliefs, and self-awareness of the participant? And social factors are, are the participants are engage into that scenario, as well as an instructor is invested in that scenario. Also the motivation and goals, culture of the group, degree of openness and trust, as well as participants' modes of thinking. Like, think of fidelity, I think, I always describe that we all go and see movies in the cinema hall. We know that that is a movie, but still we get engaged so much in that movie or drama that we laugh with the actors, we cry with the actor. If they got hurt, it give us pain, although we all know it's just a movie. Nobody is getting hurt in actual, nobody is laughing in actual. It is all a drama, but we get so much engaged, so we dismiss the belief that it is a movie and we immerse ourselves into that environment. So that is what create the highest realism, that we as an instructor not only immerse ourselves in that environment, but let our participant be so much engaged and immersed that they forget it is a simulation happening. They will deal, manage, talk. Their body language is actually as they are in an actual patient care, involved in patient care. So the next concept is, simulation-based learning activity. Simulation-based learning activity is as we are doing it. What we are doing is a simulation-based learning activity. It is for faculty development. So we are talking about how will you do it rather than actually doing it with the learner. So an array of structured activities that represent actual or potential situation in education and practice is called simulation-based learning activity. These activities allow participants to develop or enhance their knowledge, skills, and attributes, or to analyze and respond to realistic situation in a simulated environment. So this will become like, if your learner, you bring your learner, you given them that this is a 6-year-old or 25-year-old male who presented, who suddenly collapsed, and the person do not have a pulse. So you are trying to teach them about CPR, and that will become, they will do certain actions. You will talk about certain actions, which is called debriefing, which we are going to touch upon today. So this become a simulation-based learning activity. The most important thing, as I was telling you all, is a key simulation terminology, and it's a healthcare simulation dictionary. As we all learn English, I have to learn a little bit of Arabic, and I always consult to the Bibles or to the places or to books, which will tell me the meanings of certain terminologies. Likewise, it is very, very important to have healthcare simulation dictionary. This is the barcode you can scan, and there's a link up there as well. Mohammed, can you put in the WhatsApp chat the healthcare simulation dictionary as well, and they can upload or download from there. Also, be aware that all what we are talking today, me and Mohammed, is not based on our own experiences or what we have learned over time. There is multiple simulation experts and educators who come up with the healthcare simulation standards of best practices. And these standards, there are 12 standards of healthcare simulation best practices. And as an educator, I always go back to them, and I highly encourage you to keep a point to go through them at some point or other. So this is the website link, and the standards are about professional development, pre-briefing, simulation design, facilitation, debriefing process, operation of a simulation, outcome objective, and professional integrity. So these are all, each one has a different standard, and there is like what are the things you should be doing, what are the things that you should be careful of, and what are the things that we should not be doing. So each standard has its own nitty-gritties, and we are going to cover 2 or 3 of them today. 3 of them today: that facilitation, simulation design, which is scenario development, and debriefing in a very, very superficial manner, because each standard it's a full workshop of 3 to 4 hours on its own. With this, I will take a pause here, and I'm happy to take any question and comments and do a pulse check here. Any things which are coming to your mind, or any question which is not clear up till now? Or Mohammed, if you want to add on something.
It's perfect.
Please feel free to talk. There's no right and wrong answer.
Okay.
And I should say this is a very, very psychologically safe space. We know that you all are doing some form of education or other, but please feel free to ask us if you have any questions that are coming to your mind.
Okay, thank you, Doctor, for your for the session and the illustration. I want to ask you about the difference between mixed reality and virtual reality. We said something about the cost between difference between them, if I'm right.
Yeah, like there is a difference in cost. So virtual reality is if you have video games where you wear the goggles and everything is inside that goggles. So that is virtual reality. There's no connection with the actual environment. That is virtual reality. Is it clear?
Yeah.
But mixed reality is, for example, I have a mannequin, which is a normal mannequin, like a plastic mannequin. And then I'm using my phone on top of that for adding a computer technology to provide more realism. For example, they want to auscultate, but my mannequin is a low technology mannequin and it cannot make them hear the auscultation sound. So I have put a small QR code. As soon as they scan that QR code, they will hear the sound of that auscultation on their phone or any device which I have connected with that QR code. So this will become a mixed reality. Does it make sense? The example?
Yeah.
Another example
That
is
does
you
make sense.
put a QR code for X-ray, QR code for ultrasound images. So they will be in the actual sim room and they will be dealing with the mannequin. They are not making here. They did not have a goggle and they are not in a virtual environment. They are in the actual environment, but I have enhanced this actual environment by adding some elements of computer technology, which will make it an augmented reality or a mixed reality.
Yes. This is mean that mixed reality is the same as the augmented reality, right?
Yes,
Thank you.
exactly.
Thank you so
It
much.
is the same.
I got
Yeah, yes, exactly. It is the same. Thank you, Hadil. That is a fantastic question. Yes, Rami, please go ahead.
Thank you, Dr. Jabin, so much. I had one question, which is when you were talking about the task trainers, there was a picture of the robotic surgery trainer. Would you consider the robotic surgery trainer as a task trainer?
Yes, it could be if you are making your learners learn, they are being involved and you are using all the components of simulation-based activity, then it can be considered as a simulation-based learning activity or task trainer. If you are using it for simulation-based learning of a learner, then it can be considered as a task trainer.
Okay, because I had the feeling that we usually use the term task trainer for the low fidelity mannequins, but when I saw the robotic surgery, I thought that I had to ask you this question. Thank you so much.
No, that is a great question, Rami. That is again that is what I also have the same feeling. But frankly speaking, they all are based on how you are using it. Task trainer is anything that you are using it for teaching tasks to your learner. It can be low technology, it can be high technology, it can be low fidelity, it can be of high fidelity. Does it make sense?
At the end, you are teaching a specific skill.
Yes, exactly. Those are called task trainer.
Thank you so much.
No worries. Very good question. Thank you for asking. Dua, do you have to ask something? Because I saw you have unmuted yourself. Okay. So, Mohammed, I will pass it on to you now.
Okay. Okay. Okay, so I will be following what Dr. Jabin mentioned, and I will be talking about writing simulation scenarios. And for this session, I will gonna be using two examples. Let's assume that we are looking to design a scenario about teaching students how to recognize an approach for a patient with acute severe asthma. And the other example that we are planning to write a scenario to teach the students on how to break a bad news for an elderly patient with a lung cancer. So how can we write the simulation scenario for those two situations? So I will be speaking quickly about when do we use simulation, and how do we have a scenario development group? How do we write outcomes and objectives? And how do we design the scenario? It always has a beginning, middle, and ending. How can we make it complex? I will not speak about a level of fidelity. Dr. Jabin already covered that in her presentation. And then at the end, I will share with you websites that can help you to adapt simulation scenario and how to use the ChatGPT to make your writing scenario much easier and more effective. So obviously, like when do we use simulation? So in all of this situation, like in high risk situation, for example, if you want to teach your undergraduate or your postgraduate students how to respond to critical situations, emergencies that they don't see frequently, it has high mortality, like severe asthma, pulmonary embolism, obstetric emergency, anesthetic emergencies. All of these, the best way to teach those emergencies and to test their knowledge about it is the use of simulation. Like, for example, right now I have been working in anesthesia intensive care for almost more than 3 years. And throughout my practice, I had never seen a single case of local anesthesia toxicity or a single case of malignant hyperthermia. So how come I will be prepared for that case? So if I'm not doing regular simulation on how to approach those two cases, I won't be ready for them. Also, we use simulation for teaching basic communication and challenging communication. So if you want to teach your students how to disclose medical error, how to break a bad news, how to have a good connection with the patient, you will need to have a simulated teaching. If you want to improve your patient safety, if you want to test your trainee knowledge and competency, you need simulation. If you have any issues with your practice in the hospital, for example, you realize that most of your patients who present to the hospital with abdominal emergencies or with trauma, they end up having a bad outcome and you don't know what's the problem. Do simulation and you'll be able to realize what's the problem. Is it a problem with the equipment, with the knowledge, with the system? And then you'll be able to figure out what's happening. And obviously, if you are having a new process, like for example, when we had the COVID pandemic 3 years ago, and all our clinical practice has been changed with the new processes and policies, the best way to teach those is by using simulation. So if you want to write a simulation, you need to have a group of people. Yes, one person can write a simulation scenario, but it won't be as good as if you have a group. And that group should have people with technical expertise. Like, for example, with the two cases that I gave, with the asthma group, you will need a respiratory physician in that group. You might need to have an intensivist if you are writing this scenario for a postgraduate students, and you might need to have an anesthetist if you're gonna make the scenario more difficult. There is asthma patient who need intubation. So according to your purpose, you need to have people with technical expertise. And you need to have people with educational expertise. Ideally, if you have a technical expert who have a great educational expertise, would be great. But sometimes you might need to have an educational expert within that group because this simulation scenario will be used for teaching and for assessment. So if you have them within the group, they will be able to advise the technical expert on how to write the scenario properly and how to prepare it properly. Having diversity is really important. If you are able to include nurses into your writing group, that will be perfect because that scenario will be suitable for interprofessional training. And obviously, you might need sometimes ethical advisors for your simulation. And if you can include the learners and the standardized patient, that will make your group more ideal. The more you can able to do it, that will make your process more easy and more perfect. And whenever you write a scenario, you have to do dry run multiple times. And when you implement them, you will realize that there is some mistakes, there is some problem, then you have to fix them, and you have to always update them. And whenever you're writing a simulation scenario, you have to use a template. Let me share with you one of the template examples.
Mohammed, I shared one example, but I'm happy you can share one more. or you can share it afterward.
I can share it as the end. So I can share it as the end. Yeah. Just I want to show something very quickly. Yes. Can you see my screen?
Yes, Mohammed, we can see, and I shared the same template.
The same template. So
Yes.
so using a template will make your job very easy because it will guide you with the steps that you need to prepare, and also it will help you for the implementation. So whenever you're going to use the simulation in the sim lab, so the sim lab operator will ask you what equipment do you need, and it should be there in your template. If you are using a standardized patient, you need to have an instruction for that patient. It should be also included in the template. So that template will make your life very easy, and it will make your task much easier. Okay. So let's assume that you made your group for the two cases, and you have your template, and you want to write your simulation. So you need to write your objectives and outcome. So let's say for the first one, for the asthma patient, by the end of this scenario, your trainee will be able to recognize a patient with acute severe asthma attack, and they will be able to manage this patient according to the British Thoracic Society asthma guideline. So this is the outcome. And the context, so that scenario will be perfectly the best place or environment for the scenario will be in the emergency department. And if you want it for adult patient, you can choose adult or pediatric patient. And then you will write the objectives that what the students should know. So they should know how to resuscitate the patient. They should know how to assess for severity. They should know what medications and doses. And so these will be the outcomes. And they should be address all domains of learning, knowledge, skills, and attitude. They should be appropriate to the level of the student, and they should be evidence-based. So whenever you want students to learn, it should be based on guidelines, based on the current literature, and it should reflect on the whole holistic view of the patient, and it should be achieved within time frame. So if this scenario will be done in 10-15 minutes, so the focus should be, for example, on the basic resuscitation. If you want that scenario for anesthetists, for example, the focus might be on, okay, you have a very sick patient who need to be intubated, so the focus will be on that area, on that element of the scenario. For example, if you are writing a scenario about breaking bad news, again, the level of objective will be according to the learner, and whatever intervention that the students will use, it will be evidence-based. So they will communicate with the patient in an appropriate way.
ايه هو حصل ايه؟
Am I going too fast or that's okay? Okay. So whenever you are building any simulation scenario, remember that your scenario, it's like a story. It has a beginning, it has a middle, which is the core challenge of the simulation, and it has ending. So that should be reflected in your simulation scenario, and it also should be reflected in your facilitation. So the beginning is the setting for the scene to prepare the learner to see the patient and for them to have the idea about what is happening. And the middle, it has a core challenge where the students need to identify the problem. They need to do the critical actions, and they need to show if they are able to approach the patient or the problem appropriately. And then it should have a smooth ending, and the students should be helped to achieve all their objective. And most of the simulations should take from 15 to maximum 30. You can't run a simulation beyond 30 minutes. It will be too much. The trainee will be exhausted because it can be sometimes emotionally and physically challenging. So the beginning stage, you might write patient assessment setting. For example, you will have a middle-aged patient with the vital signs and findings suggested for acute severe asthma, and the patient is complaining that his chest is tight and he's wheezy and he's having a cough. And the environmental factor, you might put the patient, for example, in a room look like the emergency department, and as a nurse already approached that patient, connected him to a monitor, and she might start him on high flow oxygen. And then the learner will have expectation. So whenever they see that patient, they're expected to approach the patient with, for example, ABCD approach, and then from that beginning, you're gonna take the learner and the patient through the scenario. If we are talking, for example, about a scenario for a breaking bad news, so it will have a different setting. So, for example, the trainee, let's say, for example, the relative will be in a room, and the trainee are supposed to go to that room to speak to him about that his results shows that he had a lung cancer. So the environment might be a room with a seated, and then the trainee are expected to go and speak to him with following a specific protocol for breaking bad news. And then from the beginning, there should be a trigger that could be a facilitated action or a mannequin setting or timeline. So for example, let's say if we are doing, for example, a resus scenario, we can say the patient arrested. So then the trainee will realize this is a cardiac arrest. They have to follow the arrest guideline. For example, the facilitator might say, this is your patient with acute severe asthma. He's more distressed now, and his vital signs are, his saturation is dropping, his pulse rate is increasing. Or maybe a timeline. After 5 minutes, you're expected to do so and so and so. All this could be a trigger. And that will take you to the middle phase of the scenario. And during the middle phase, the patient will have different findings, and then the environment might change, and the trainee will have different expectations. So now he realized that this patient is having acute severe asthma. He will need to continue assessing the patient. He will need to prescribe a bronchodilator. He will need to take an ABG sample. He will need to request a portable X-ray. So all these expected actions is listed, and the facilitator will give the trainee a hint so he can walk through all of these steps and demonstrating all these steps. And then we end the scenario, and we have to be prepared. If the candidate did all the correct actions, then we can end the scenario. If he missed some actions, what will be our strategy? And if he didn't do many actions, what can we do? So that should be clear in our simulation. So it should end in a proper way, to like in appropriate way. So we should be helping the trainee to achieve most of the outcome before we end the scenario. And we shouldn't be killing the patient or putting the candidate in too much challenge to achieve the objective, because that will affect the psychological safety of the simulation, and it will affect the learning and the whole experience. So after that, after you write your simulation, you can make it more complex if you want. But whatever complexity that you want to achieve, remember, it has to support your learning objective, and you have to remain realistic. So, and it has to match the level of learner. So you might make the patient with severe asthma very sick, so that he will need lots of medications beyond the basic medications. And the trainee have to think of magnesium sulfate, theophylline, and intravenous noradrenaline, and intensive care admission. So if the trainee is at that level and he expected to do that, you can do it. You can make the breaking bad news scenario very difficult, so the patient might become very upset, very angry. So the trainee can use more communication strategy to calm that patient. And these technical challenges can be like new equipment, triggers, psychosocial aspect of the patient. Maybe you can bring a patient with a different language, or patient has a language barrier, or the patient might have comorbidity. So a patient with a history of heart problem, so the trainee will be thinking, is that a heart failure or is that asthma? Or contextual aspect. All of these, you can throw them to make things complex, but remember, make it realistic, match to the level of the learner, and support the learning objective. It's not because you want that, it's because this is how it helps the trainee to learn and to develop himself. So most of the time, to be honest, like me, in most of the time, we don't write scenarios from scratch. Most of the time, we look on available scenario, and we adapt and modify them, and we mention that has been adapted, modified from that source, and we put the link. And if you want to go and look for a scenario, your first real website will be the MedEd portal. This website has been established by the American Association of Medical Schools. They have lots of educational material for small group teaching activities for simulations, and they have lots of simulation scenarios. Most likely, if you are having any plan for any simulation, you will find something there. So instead of you starting from scratch, go there, look at the scenario, and then you can adapt it. For emergency medicine, the EMSIM cases is a very good website. And if you want to do virtual simulation, the virtual registrome will be a good option. And sometimes we just Google it. So you can write your topic, you can write simulation scenario, you will find different options, you will download them, you will modify them, and always it's ethical practice to mention the source and to mention that in your simulation, this has been modified and adapted. And if you can contact him and ask for permission, that would be even great. The ChatGPT now is really very important friend of us. So you can use the ChatGPT, it will help you writing the cases, writing the vignette, writing the results, and it can make your life very easy. The only problem with the ChatGPT is that it might not give you an accurate information. So if whatever you have, you need to review it by your committee and ensure that it's inaccurate. And you have to use the appropriate prompt. And let me show you some demonstration. Let's say you want to write, So let's say you want to write a standardized patient simulation with a differential for a 30-year-old man who present with cough, and you want the differentials to be bronchiolitis, acute reflux asthma, or lung cancer. So you're going to write your, can you see my ChatGPT webpage?
Yes.
Yes,
Yeah.
yes, yes. It's
So you have to write the prompt properly. So you say, create a case vignette for a standardized patient, a 30-year-old male. His name is Sabir. Okay. He with cough, he might have chronic bronchitis, reflux, asthma, including chief complaint history of present illness. And you boom, you just send that prompt, and the ChatGPT will give you all the patient history. Usually 1 or 2 minutes, but it will give you the full history. So it'll give you the chief complaint, history of present illness, past medical history, family history, social history, and review system. So then you look at, so if you can see, so 30-year-old patient, his name is Sabir, present with persistent cough, history of present illness, past medical history, social history, review of system, physical examination. And you can go ahead and add more prompt because you want that scenario to be written in non-medical language. And you want that to be written in Arabic. And even in Arabic, you want it to be written in Egyptian style language. You can do that. So he will rewrite all of that for you in a patient language, in Arabic language, and in Egyptian kind of format. Again, it might not be the perfect Egyptian style. You might still need to make some tweaks and modification, but the ChatGPT can help you. Like it can help you writing the learning objective for the simulation. It can help you writing the case. It can help you writing the examination finding, the investigation results, all of these. It will just save you the writing time, and then you will need to double check, make sure that all the information are accurate. It should generate that within a few minutes. And also the ChatGPT can help you creating questions for the simulation. So if you want to create MCQs or single short answer questions that you want to use as a pre or for post simulation learning, the ChatGPT can help you with that. It's really very powerful tool. And yes, it won't replace you as a faculty, but it will make your life very easy. It is translating that. I think that will be the end of my presentation. So, any question, any comment? Yes, yeah. Can you see? Can you see my ChatGPT?
Yes.
Yeah.
The first time I know they write in Arabic, actually.
Yeah. Can you see it has some kind of Egyptian accent. It might not be perfect one, but again, you can always change that, modify that, because eventually what will you be giving to a standardized patient to portray? So it has to be in Arabic language, and it has to be common language, yeah. So it can make sense to the trainee. Okay. So that's it. Any question, any comment? Dr. Turki, you're welcome.
No, thank you for the clear and informative presentation. I hope we made use of it, especially the part of the AI, ChatGPT, that it can help us more. Yeah, that's very nice.
Dr.
Thanks
Hannah,
for
we have a
Dr. Bais.
question. We have a question.
اتفضل.
Thank you.
Yeah, in the chat.
Yeah, Dr. Hala, I am Dr. Turki.
Okay.
Dr.
Dr. Turki.
Yeah.
Okay.
I am Dr. Ali Turki, Professor of Surgery. Thank you for this informative presentation, Dr. Jabin, Dr. Muhammad. I have one question for Dr. Jabin and the other for Dr. Muhammad. For Dr. Jabin, how and where to include the simulation-based learning in the core curriculum?
Yeah, that is a very, go ahead, Mohammed.
I will be talking about that in my upcoming presentation. So if you wait for me, I will have a slide for that so I can answer that in detail. If you want me to answer right now, I can answer it right now. But if you wait, after probably 20, 30 minutes, I will be explaining that in details.
So we will be parking that, Turki. And if it is still not clear, we are happy to discuss it a little bit more or elaborate it, okay?
Okay. As a second question can be?
Yeah, please
Okay,
go ahead.
Dr.
Dr. Muhammad, for ChatGPT, you put your prompt for any case, not for simulation. You make a vignette for any case, but you could not specify it for a simulation.
So basically,
how can to use the plugin in order to benefit from the plugins in designing the simulation, and if you would like to put a photo or something like this?
As far as I know, right now, the ChatGPT cannot give you a full simulation template. Like, it will not give you that. But what can you do if you look at the template that we shared in the WhatsApp? So let's say the scenario title. So let's say you wanted to do a simulation. Let's say you are a surgeon, so you wanted to do a simulation on acute abdomen. Okay.
Yeah.
So the scenario title will be acute abdomen. So the ChatGPT can help you writing. Let me just share quickly. So your simulation title will be acute abdomen. So the ChatGPT will help you writing your goals. Again, like, I know how to write goals from medical education point of view, but it used whenever I'm writing objective, writing those objectives properly and double check them and ensure that they are written correctly. It used to take time from me. From ChatGPT, I can say, okay, learning objective so you can just write learning objective for acute abdomen simulation session for example, second-year medical students, and then ChatGPT will give you examples. You can modify them, you can tweak them. So that will be done very quickly for you. And then you will go for the vital signs. So you can ask ChatGPT, I want a case study for acute abdomen. So if you want in a male or a female patient, the patient age, including so and so, including the vital signs. ChatGPT will give you the vital signs. You will copy and paste them. You want a full patient history. You will copy and paste it here. And then what equipment will be required. So ChatGPT will help you answering all of these questions, will give you a suggestion. It will make your job very easily. Instead of starting from scratch, you'll have some information that you can modify, change, and tweak. And until you finalize the whole kind of, the whole template, ChatGPT can help you with each step. Does that
So-
answer your question?
Yeah, Mohammed, I want to add on. Yes, Turkey, you're right. The utilization, ChatGPT is only one model of artificial intelligence, which will help you to develop a scenario or plan your simulation-based activity in a shorter time period. It is not a simulation in itself. It will help you to prepare quicker for your simulation-based learning activity. There are multiple AI-based platforms which are in evolution, which will provide you more self-directed simulation scenarios. And what I meant by, one of my colleague was showing me, which he is developing, and I'm working with him. Like, for example, like the ChatGPT or AI is your simulated participant or a simulated person, and you are taking the history, you are doing a communication. It is only for communication and history taking perspective. And then the ChatGPT will become that patient, and after the session is completed, the ChatGPT will provide you feedback on how your history taking was, whether you were complete, whether you were empathic, what was your body language, like in terms of how was your sound, voice was, is it questions were derogative, it is culturally appropriate, etc., etc. So this is coming up. And then if you look at various applications, like they are being evolving, where you will have a self-directed simulation scenario on cardiac arrest, which is an application, phone-based or tablet-based application, where I'm a learner. One of the example is Full Code. Mohammed, can you share the link of Full Code? It is an
Yeah.
application where you will just choose your own venture. You will ask people question, they will respond to you with the history. There are nurses that you interact. So these are a couple of examples. It is not fully mature yet. People are introducing it, but it is going to evolve in a lots of self-directed learning and simulation-based scenarios. But right now, the AI or ChatGPT are being utilized for such applications only. And you are right in saying that this is not a full simulation-based activity. It will help you in designing or planning for a simulation-based learning activity. Does it clarify, Turkey?
Yeah, just verify. Thank you, Jabin.
Perfect, great. Thank you for asking such an amazing question.
Thank you.
While Mohammed is taking some question, I would like to show you some of the websites that he shared for. This is a virtual resuscitation room. And then if you go to the ready to use run cases, here there are, you can see so many cases of peds, adult, out of hospital. So for example, if I choose anaphylaxis, there's the whole scenario here, anaphylaxis case. It will open it up as a full simulation ready-made case. Definitely you have to tailor it, like this is the full SIMS case. The other is the MedEd portal. And if you search here, for example, if I have to do a case on diabetic ketoacidosis, so I put a DKA, and here all the cases which are available regarding DKA will come up, and you can go into then, for example, I want this case. So they will be whole, you can see in appendices, all the cases, slide, picture, ECG will be present. And then the EMS SIM cases, you can do by the category. For example, I want pediatric cases, then it will start showing up the pediatric drowning case, they have a bronchiolitis case, etc. And if I click, for example, the bronchiolitis, all the case, the pictures, etc. will be here, and you can just download and the case will be fully downloaded. So please do not try to reinvent the wheel. The literature is full of such resources, and you can just download it and tweak it with your own setting, according to your own setting. Mohammed, go ahead.
And also the MedEd portal website, they don't share their simulation resources, they share the whole experience as a publication. So
Yeah.
it's a chance for all of you, like I would say, most of the current simulation literature are derived from North America and Europe, and there is no many literature from the Middle East. So it's a chance for any one of you to start implement something, and then you can share that experience on that website, so that can be a publication counted for you. Think about it, yeah.
Yes, exactly. And anyone want to work on any of such project, me and Mohammed are always here to help you out. And I have Nazish here. She's one of my colleague from Pakistan. She's a assistant professor in pathology. She's implementing a lot of simulation-based education in basic sciences. So we have a big misnomer that it can only be utilized for, we talk about a lot in resuscitation, in acute care, because Maya and Mohammed background is that clinical background, but it can be implemented into any specialty, starting from basic sciences, physiology, pathology, to non-acute versus acute care settings.
Yeah, and also, Jabin, it's good to share our last experience about using the simulation to teach clinical reasoning.
Yes,
so,
exactly.
Like simulation can help a lot with clinical skills teaching in the undergraduate curriculum. You can use it for communication skills teaching. You can use it for the physical examination teaching, and then you can use it for clinical reasoning teaching. And I think, like when I used to work in St. George's University, I used to have a very big class. My class size was between 700 to 1,000 students in one class. So teaching all of those students clinical skills, we don't have a hospital to fit all of those students. So the best way for me to teach those students who did not start their clerkship yet is to use simulation. So we use simulation, and we were able to cover most of the basic clinical skills, history taking, physical examination, clinical reasoning, in a very nice way, and prepare them for the hospital rotation. I assume the situation in Egypt can be similar. Most of the medical school, you tend to have big classes, and you don't have easy access to the hospital. So the hospital can be left for the advanced students, like students in year 5 or year 6, and then the junior students can be taught clinical skills most of the time through clinical simulation. And if you look in America, in the nursing curriculum, they are accepting that 50% of the curriculum can be taught in simulation. So people can use simulation to compensate for the lack of access for a real patient. It's not a substitute, but it can expand and compensate for that.
Yeah, Rania has a very interesting comment that simulated person or actors or role players are not all-time expert. Completely agree. That's why they are supposed to get training, and they are supposed to get the whole script, that how they are going to act upon when a learner is going to ask you a certain aspect. And it's very, very costly as well. Their time, their training, standardization is very resource intense. That is why we use it all the time, our faculty member or content expert. For example, when we do a adolescent medicine mental crisis scenario, we ask our adolescent medicine or psychiatric colleague, nurses, social worker to become a standardized or simulated person or patient or actor, whatever you want to call, or anybody. Like we have a couple of people who are interested in mental health crisis in the emergency department. They become our role players or simulated person or participant, because they know what are our problems, rather than spending our money I will
Yeah.
tell you now there are whole virtual reality or AI-based simulated person programs where a learner will be interacting with a virtual person. Like it is a avatar with which they are communicating, and then avatar will provide you whole feedback. So you will assign certain avatars based scenarios to learners, and they will interact. They will give you feedback. That feedback is generated or downloaded as a PDF, and it will go to your facilitator, supervisor, or to your teacher, who will look how was your interaction. So there are many ways that have been evolved, but there are some which are resource intense, they are cost intense, and there are some which is your substitute in a low cost, but it will give the same kind of experience. Thanks for bringing that important point, Rania. Mohammed, do you want to talk about facilitation now, and then I will go to debriefing?
Shall we give them like 5 minutes comfort break?
Yes,
quick
that is a
coffee
good idea.
or
Yeah, we
Yeah.
will come back at 8:20 your time and 1:20 our time. So just 8-minute comfort break, and then we
Yeah.
will come back. Grab, like, if it is a
Yeah.
prayer time, or
yeah.
if anything you want to get some coffee or tea, please feel free. So we will start our next presentation in 8 minutes.
And it's better to stay, in the Zoom. You need to log out and log in. Just you can turn off your mic and your video.
Yeah. Back if you're just please show a thumbs up, write a text or message to let us know.
Okay, Assalamu alaikum once again, and welcome back. I'm waiting for all to share. So we will put in the chat one for form for the feedback and the other for registration for the certificate. Please all fill these options. Okay, I will repeat. I think we are not all returned. Okay, Dr. Muhammad will start.
Okay, that's okay.
Okay, let me announce again that there will be two in the chat. There will be two connection, one to register for the certificate and the other for the feedback. Please fill it at the end of the webinar. Okay, all participants, please fill the feedback and register for the certificates. Dr. Nancy will put it in the chat. Thank you. Dr. Muhammad, you are welcome.
Okay. So I will be talking about how do you facilitate a simulation session. And again, I will be mentioning general concepts, and you have to remember, dependent on your type of simulation, things can be tweaked. So if you are using a standardized patient simulation, it's different from mannequin-based simulation, it's different from virtual reality. Some changes might need to be modified, but I will be giving general concepts. These general concepts should be followed regardless of the type of the simulation. So I will be just quickly speaking about the simulation modalities and the flow of simulation scenario, and how do you set the log and close a simulation scenario, and how do you integrate simulation into your current curriculum. So these are the commonly used simulation modality. So the task trainer, or the mannequin-based simulation, or the standardized patient simulation, or the virtual reality and the augmented reality. And in fact, you might combine two modalities together. So for example, you might use a task trainer and a standardized patient together. For example, you want your trainee to do, for example, a breast examination or a pelvic examination on the patient. So the patient herself might wear the breast model, or she can just put it next to her. So when the student is about to examine, they are examining the mannequin and speaking to the patient. It will give you more kind of fidelity, and it will allow you to teach and test more superior objectives. So before the simulation, as I will explain later on, simulation should be part of your curriculum, and it should be very clear for the students when are they having the simulation sessions throughout the course or throughout the curriculum. So it shouldn't be like a haphazard or like a surprise or unplanned activity, because if you do that, you won't be able to achieve the objective, and it will be a waste of resources. So it should be clear part of their curriculum in the undergraduate or in their training, or for the postgraduate. They know that during this kind of rotation, they are expected to have the simulation happening on that day, on that particular location, on that particular time, and they're expected to cover so and so and so and so. And ideally, they should be given a preparation material before the simulation. And if you have an online learning platform, then you can post these for the students in advance. Like, for example, next week we'll be having the following simulation. This is the expected reading material, videos, or whatever. And then after the session, you can share with them the model answer, and you can always support that with pre and post assessment. So that's really important. And then your faculty should be prepared, especially if you are using a junior tutors. You know, in most of medical schools, they tend to use teaching assistant who they don't have huge clinical or teaching experience. So if you are depending on them to run these sessions, you need to have a detailed faculty guide that shows the expected pre-reading, that shows the expected actions with the checklist, with teaching notes, and obviously you need to have a frequent preparation sessions for the faculty to ensure that they are doing these simulations properly. And as we explain the way that we develop the scenario, we do the same thing for the teaching. Also for the teaching, we have to set or prepare the trainee for the simulation, then we have to run it, facilitate it, and then we have to close debrief at the end. So we need to go through all of these stages. And one of the common mistakes that the trainee do, they tend to spend so much time in the initial setting or initial beginning, and they don't give the trainee a huge time so they can reach to the middle phase of the scenario and do the expected action. And eventually, when they end up cutting the scenario because they don't have time, it will be very difficult for them to give a debrief because the students will not be given chance to demonstrate. So the point is, whenever you are doing simulation, remember, the meat in your simulation is in the middle phase. So you have to walk the trainee quickly to reach that phase so they can do their expected actions, so you can give them feedback at the end. Don't waste your time a lot with the beginning, and give them enough time to go through all of the expected actions, and then end the scenario properly so you can prepare them for the close and debriefing. And on the picture on the right is a real scenario where we are doing CPR for a patient who is arrested. So we wanted to make our simulation experience as real as we can. And this is what we call fidelity. And for us to do that, we need to look at the different aspects of fidelity. So we need to make sure that at least we have a mannequin that look like. Sometimes if we are having a trauma patient, we add moulage, like for a burn. If the mannequin is having burn, we add some burn marks, for example. We add some deformities. If it's a pediatric patient, we are bringing a small mannequin. So make sure that the physical fidelity is the same. And then also, when you are designing your scenario, make sure that when you design scenario, it makes sense. So if you are giving them a severe case of asthma, the vital signs should reflect severity. And when they are doing the right intervention, the patient should improve. It's really sometimes some instructors tend to trick the candidate by giving them unreasonable difficulty. That will defeat the whole purpose of simulation experience and will make the whole experience very painful, and it won't be a good learning experience. So if they did the right actions, the patient should respond to their actions. If they miss those actions, then it will be your responsibility to give them cues to help them. Remember, you are not there to fail them. You are not there to defeat them. You are there to guide them through the experience. So you have to maintain the fidelity. And also remember, when you are doing the simulation, it is not a discussion on top of a mannequin. It's a simulation. So the trainee has to perform actions, and based on their actions, they have to get a response from you. And this is what we call it cueing. One of the common mistakes that we see in simulation is that the instructor is talking too much and is not allowing the trainee to do any actions. And then all the instructor and trainee are just talking together, and the patient is lying in the middle. Once you change the simulation to a discussion, you won't be able to achieve the objectives that you want to achieve. Remember, you are doing a simulation, not a discussion. So as I said, you have to maintain your fidelity. So the physical, the equipment and the environment, the psychological, the task and the function, and then the conceptual. So if they are not recognizing that the patient is hypotensive, you can always bring the blood pressure a little bit down, make the patient more tachycardic, so they can recognize this is a shock. And if they give the right fluid, for example, or the right medication, then the patient will improve. So you are always making sure that the scenario is reasonable. So prompting and cueing in simulation is really important. And we do two types of cueing. So we do conceptual cueing. So we try to give them prompting that will help them to reach the objective. For example, a scenario of abdominal trauma. So the trainee are approaching the patient, and they should realize that this patient is having a hemorrhagic shock. They have to resuscitate this patient. They have to do a bedside ultrasound. This patient is not stable to go for a CT scan, and they have to call the surgeon. So these are the expected actions. So we have to give them cues to help them realize that. Okay, so for example, the trainee is approaching the patient by doing the ABCD approach. He's asking about circulation. Don't give him the finding until he showed that he's checking for the pulse. He's checking for the pulse. He will ask what's the pulse. He says the pulse is 140. He's checking for the blood pressure. The blood pressure, you give him a low blood pressure. So you are responding to his action by giving him a prompt so he can realize that this patient is hypotensive. If he didn't realize, you can make the situation a little bit worse for him to realize. Sometimes we tend to whisper to one of the group member so they can tell the trainee that this patient might be having a shock. We may need to give fluid or blood. And sometimes we give cues. For example, if the trainee didn't realize that this mannequin is distressed, we can say, look at the chest. This patient is distressed, because sometimes we might not be able to show the distress on the mannequin. So we have to give this prompting so we can open the eye of the trainee so they can realize what's happening. So how do we set dialogue and close, or prepare, facilitate, and close the simulation? So we prepare. So we check and adjust the layout and the equipment. So in the room, the candidate should be able to approach the mannequin from each side, and the equipment should be all available. If you have an assistant, make sure that your assistant is aware of the simulation and aware of his role. And then you welcome them, you introduce yourself, let them introduce themselves, and establish why this session is really important and what are the objectives from this session. And then you inform them about the code of conduct and the confidentiality. Sometimes we use the fiction contract or the Vegas rule, whatever it happened in Vegas, stay in Vegas. We remind them that they are intelligent, capable, caring, and they are doing their best. We are not judging them here. And what are you trying to do? You're trying to establish a psychologically safe environment. And at this point, I would be happy if Dr. Jabin expands this point. Like many people don't really understand why psychologically safety is important in simulation.
Yeah. So we as always like how we are being taught, like if we are not allowed to make any mistakes when our teacher asks a question, what happened that it will make us either not to speak up at all, or if even by mistake sometime we answer and that turns to be wrong, we completely get shut down and we are not ready to learn. So that is the beauty of simulation. Like there are many sim centers which has written that this is an environment where you are allowed to make mistake, so that we know where are your lackings are. You can ask anything right and wrong, and then you are going to learn, because this is a simulated environment now. Even if you are doing mistakes, because you have a lack of knowledge, this is your moment to learn from those mistakes, so that when you go to the patient care area, you will not make that mistake. But then making your learners to be at that stage, you have to create that environment or psychological safe, where they are ready to keep their minds open, they are ready to make mistake, and they are ready to learn despite of making those mistakes. So if you go to back to the learning theory and the adult learning concepts, there's a cognitive load and there's a germane load. So if you make the cognitive load high or germane load high, learner is not ready, the mind is not ready to learn anything. That is why you will reduce the cognitive load by making them say it is okay if you do wrong, because that is why we are here, to see where are some of the gaps and how we can make that gap better. So that is a big mindset change in our teaching or educator mindset, that it is okay for them to make mistakes, and we have to say it very upfront and encourage them to speak up, and it is allow them to reduce their cognitive and germane load, so they are ready to learn and apply that learning when they go back to their clinical environment. It's a very, very big concept to learn, and frankly speaking, there are whole set of literature there, how to create even the sitting arrangement. Like if you are sitting in front of the students and the class is like that, you are not causing this environment a psychologically safe environment, because you are look like as an authority and whatever you are saying is the right thing. No, I am also a human being and I have also limited learning. There is a possibility that there are few things which I do not know, and I'm happy to expect it's a good question. I am not sure about it. I will look. So even making them sit in a circular environment is a very, very smaller way how you will bring yourself as an educator to the level of learner and make the conversation as a circular conversation. So this is where the concept of power distance comes in, that normally in our environment like Pakistan, India, Bangladesh, Sri Lanka, Sudan, Egypt,
Yep.
teacher is the authority. Whatever teacher say is always right. No, it is not like that. Your learner may also bring up some points which are very rich and very knowledgeable. And then when you create, like, for example, I can show you in one of the article, it is such a wonderful picture when they say when you create a psychologically safe environment, the conversation rather than a triangle, like me talking to Muhammad and Muhammad talking to me, and then me talking to Hala, Hala talking to me. This is not a good psychologically safe environment conversation. When it is a psychologically safe environment, the conversation becomes star-shaped. Me talking to Muhammad, Muhammad talking to Hala, Hala talking to Maryam, Maryam talking to Noha, Noha talking to me. So it become a star-shaped conversation, because you have created a psychologically safe environment where everybody is open to speak up, to correct each other and to learn from each other. So I hope I will have explained, it's such a short time, but just to give you an idea, what does it mean and how you can create a psychologically safe environment by saying it up front, by telling them, I'm also do not know everything, putting yourself in their shoes, and then allowing them to have that conversations.
Yeah, thank you so much, Dr. Jabin. So it's really very important to establish and to maintain that psychological safety throughout the scenario. And it's not about you. Even sometimes some of their colleagues might be dominating, might not behave appropriately. It's your responsibility as instructor to ensure that everybody who is attending your session is psychologically safe. They are here to learn and they're not being judged. And even at the end, even if they didn't do well, there is lots of debriefing strategy that can help you, telling them that you didn't do well in a way that doesn't hurt them, but still help them to realize what are their mistakes and how can they improve themselves. And orient them to the simulation room, to the mannequin, to the type of equipment. Especially if you are doing a couple of sessions, you can do that in the first session, and then you don't need to repeat that every time. Okay, and then once you start the simulation, you will use your cueing to direct your simulation. So whatever they are, you give them the brief history. They will approach the patient. Then you give them the cue. Okay, so they ask about the vital signs. You have to ensure that they do the actual examination so they can get the vital signs. They ask about investigations. Give them a time. Okay, I took an ABG sample. The ABG sample has been sent. Give me 2 minutes. I have to check the system, and you print the ABG. This is the ABG result, and you have to maintain the simulation fidelity. As I said, one of the common errors that sometimes the instructor are talking too much and they convert the whole simulation to discussion over the mannequin, and that will defeat the whole simulation purpose. Allow them to demonstrate critical actions. So in this patient, the trainee are expected to do the ABCD approach for the patient, prescribe the medications for the acute severe asthma. They are expected to request ABG and interpret the ABG. They are expected to request a chest X-ray and interpret that. And when they do the actions appropriately, show them the appropriate actions in the patient. And if they are failing to do that, try to use the prompting and cueing to help them. And you should never kill that mannequin to give them a lesson. That will defeat the whole psychological safety issue, and it can give them trauma. And especially in the postgraduate simulation, if you are creating a psychological unsafe simulation, the trainee will start avoiding those sessions, and they won't be showing up for them, and they won't be learning from you. And you have to encourage them, and you have to ensure that they are showing the technical and non-technical skills. And when we say non-technical, I mean the communication skills, situational awareness, the leadership skills, all of these. You have to keep check on safety. So if you're using defibrillator or if you're using sharps, you have to make sure that they are using that appropriately. And you have to keep to the time, and you have to maintain psychological environment. Once you finish the simulation, you have to make it clear for them that the session is finished. Let's have a discussion. And ideally, you should be away from the mannequin or away from the patient. They should sit together, and then they should open the discussion on debriefing. So you prepare the debriefing environment, you start the discussion, you explore, and Dr. Jabin will talk in details about, will address the debriefing in more details in her session. The most important thing about debriefing, you have to use a standardized debriefing methodology. There are many debriefing tools. Some of them have been validated and have been studied. So you have to use one and adopt one, and you have to use it properly. So you can give debriefing feedback to your training. And that will be the end of this facilitation. So how would you integrate the simulation into your current curriculum? Again, it has to follow the standards for curriculum development that has been developed by Kern. So you have to make a case. So in your medical school, like we have no simulation, we need to have a simulation because certain objectives, they cannot be taught properly or assessed without simulation. For example, clinical skills like communication skills, you need simulation. Physical examination can be done at real patient, but again, when you have huge classes, when you are talking about junior students, you don't need a real patient. You might save the real patient for the more advanced students. All the emergencies, all the rare situation, the crisis, it needs simulation teaching. So obviously, if you don't have simulation, you're not teaching those topics properly, and then your curriculum is deficient. Then you have to think, okay, I have these problems. I need to have simulation. I need to start that in my medical school. I need to have resources and infrastructures. So I need to have a simulation lab. I need to have basic equipment. And if you are using a standardized patient, you need to recruit and train them. And ideally, you need to have a trained patient. But according to my experience, when I was in the Caribbean in St. George's University, our program, we haven't used a professional actor. We just used local people. We bring them, we train them, and they were doing okay. You know, if you are using simulation for undergraduate students for basic clinical skills, it can work okay. It's not the best, but it can work very good, and it helped us teaching our curriculum, and even it helped us with our OSCE exams. It's really very important to have a clear curriculum map, because when you have a curriculum map, it will help you plan which objective will be taught through simulation, which objective can be taught by different methods. For example, like if you want to teach physical examination, you don't need to have a proper simulation. You can simply bring volunteers for the students so they can practice examination on them, and that's it. So you need simple skills teaching sessions can help you with that objective. However, if you want to do like a full experience with history and examination and reasoning, then you will need a simulated patients, and so on. So you need to have a clear curriculum map. You need to train your faculty on simulation. You need to help them writing scenario development, and you need to integrate that with your theory teaching, practical skills teaching, and with the bedside teaching. You can't teach without assessment. So if you are using simulation teaching, then you have to use that in assessment. It has to be part of your final OSCE exam. And also you have to give the students continuous feedback. So while you're using the simulation for their teaching, you can give them formative feedback. And then at the end of the exam, when we're using simulation for summative assessment, you can also give them feedback if you want. Continuous evaluation is really important. And as I mentioned, if you are implementing simulation in your medical school, this is an opportunity for innovation and research. And again, most of the literature about simulation are from North American, European. There is very limited literature from the Middle East. So it's a chance for any one of you to be a pioneer and to start implementing that. And that's the end of my presentation. Thank you so much.
And I would like to say one comment here that we are teaching about simulation as one of the technique. It doesn't mean that for everything you have to include simulation, like all the curriculum should be simulation based, or like it is everything will be done by simulation, or all assessment should be simulation one. There should need to be a right mix of everything. For example, if you just want to teach them what is septic shock, then simulation is not the right place to do that. But if you have to assess or teach that how you will work as a team in managing a septic shock patient, then probably simulation is a better methodology to utilize, because knowledge can be given as a lecture. For example, right now we are doing a knowledge translation or cognitive most kind of knowledge sharing. So this is the best avenue. But if we have to make you all develop your scenario and then practice doing that scenario, half of you becoming learner and half of you becoming facilitator, then probably doing a simulation will be a better way of learning about it. So always keep a mix that is fitting your learning outcome, that is fitting your assessment, what you are intending to assess. So I just want to make this that we are talking about simulation-based technology, but it doesn't mean that everything need to be simulation-based. So I will go very quickly to the last part of debriefing. I know I have only 10, 12 minutes, and I will be very, very briefly and quickly touching about it to give you an idea. But as I said, there are like almost like
Excuse me, Dr.
Yeah.
Japin. Excuse me, before you start, just I would like to thank Professor Dr. Mohammed for the valuable, informative presentation. And just I want to remind the participant that in the chat we have two links, one for registration for the certificate and the other for the feedback at the end of the webinar. Please don't forget. Okay, thank you, Dr. Japin. It's the floor for you.
Yeah, thanks, Hala. And please fill up those forms, as it is very important for you to get the certificate and very important for us to get some of the feedback from you, what other topics you want to hear from us, and it will help us design the future kind of core webinars or etc. So coming to the debriefing practices in simulation, no disclosure, and the purpose is to just introduce a little bit of principles of debriefing. What is the difference between learner versus facilitator-led method, and some of the strategies that you can incorporate into the debriefing methodologies. This is our sim lab just to show. So simulation-based practice paradigm, as Mohammed was showing, that it is all start from need assessment to evaluation. And today here, I'm going to talk about debriefing. Before I will start debriefing in any session, and particularly also in this session, that I have a basic assumption that everybody of you participating in this session is intelligent, capable, does their best, and want to improve. So this is a very, very important assumption that we all will have as an educator. And many of the sim centers or places where simulation-based activities happen, they have made big posters and put it there. And this is one of the strategy to create a psychologically safe environment as well, because you are saying upfront that all of you are intelligent, capable, and you are trying your best and doing your best and have an intention to improve. So this is an important basic assumption that we should always have in our mind and always will be upfront to our facilitators. With our learners, sorry. If we look at the definition of debriefing, debriefing by definition is just a form of discussion between two or more individuals in which aspects of a performance are explored and analyzed with the aim of gaining insight that impact the quality of future clinical practice. So there are a couple of things which are very important to have in mind, that if I am a facilitator in a simulation-based activity and I'm seeing learner performing, I will refrain myself for self-judging them. If they have not applied oxygen on an 89% saturation, I will not assume that they do not know how to manage an airway. Because always remember, one of my mentors say that, and I always repeat it, that you will see what is happening, you will hear what they are saying, but you do not know what is going on in their mind when they are doing certain action. So what you are trying to do here during debriefing, you are trying to understand their mental frame, that if a gap has happened, why that gap has happened, what was the reason behind it. So it is possible when I ask that, Mohammed, I noticed the saturation was 88% and it took you 2 minutes to apply oxygen. I want to understand what was going on in your mind at that time. And Mohammed will say, I was the patient, like I was so busy in getting the IV access and giving the boluses to the patient that I even did not look at the monitor that the saturation has dropped. And as soon as I realized, I applied oxygen. So what happened here, he know that if the saturation is low, but he could not do it because there are multiple tasks and multiple priorities that he have to do. So that is why it is, then it is not a knowledge gap. It is the gap that there are multiple tasks will need to happen at the same time. So your discussion or your strategy will be focused on how will you do multitasking? How will you do actions when there are multiple competing priorities? And your discussion will be focused on there. Rather, if we say, oh, I do not know what to do if the saturation is low, that is why I was looking upon to my team leader to give me guidance. And then you will talk more about the medical management of airway. You know, it happens when we in such a stressful situation and we do not know how to manage airway. So these are some of the guidelines how you will manage an airway. So that is why it is very important to explore and to analyze that why certain actions happen so that you will provide them an appropriate guidance. So if you look at the literature, that what make the debriefing effective, the debriefing will be effective if you create a supportive environment. If you allow the trainee to speak up, to give them a confidence that they will be okay if they have done mistakes, as long as they are willing to talk about it and willing to learn and then not to repeat it again. You will provide them specific and concrete observation. Like I did, I talk about a specific example. I didn't said, oh, Mohammed, you do not know how to manage an airway. Can you tell me why you did not manage the airway? And then he will say, no, I managed the airway properly. The saturation will go down. I applied oxygen. I started ambu bagging, etc. But when I giving him a specific example that this was happened and this is what making me concerned, then he will give me more concrete idea that what it happened, why I'm asking that question. It need to be honest, but not threatening. It doesn't need that you will be the sandwich approach that we used to hear. Talk about good thing, then talk about bad thing, and talk about good thing again. It is now like quite outdated from the literature because everybody know and they keep on asking, okay, I know you will say I am good, but I'm not very good, but I'm good. So what does it mean for me? It doesn't mean anything for me. So tell me specific. So learners do appreciate honest feedback if you are willing to support them. And then trainees have an opportunity to share their perspective, and the focus is on improvement. The focus is not on penalizing someone, penalizing that you are useless, etc. If you put a focus on improvement, people will be willing to be more participating in such conversation. Even if they have done the mistakes, they will still open to share and talk about those mistakes. There's a huge misnomer that if the debriefing is like that, so why don't it's called feedback? So there is a lot of difference between, like, it is of, there are some similarities with the feedback, but it is quite different than the feedback debriefing. Feedback is review or critique, usually instructor dominant. Like I have reviewed somebody's performance and now I'm giving him one-way conversation about how did you did. But debriefing, instructor only facilitate, and the discussion is mostly learner-led. It is multifaceted, two-sided or multi-sided, and everybody is providing and talking to each other. That is a major difference between feedback and debriefing. That feedback is facilitator-led. It is usually a one-way conversation, while debriefing is facilitator, instructor facilitate, but not lead it. It is usually discussion among the learner and instructor facilitate and push it in the right direction. And it is multi-directional rather than unidirectional. As Mohammed was saying, there are multiple frameworks in the literature that talk about debriefing, but the most widely accepted one is PEARLS. There are full like a day workshops on Pearl debriefing methodology. So I'm just going to talk very, very briefly about it. It has got this phases, which is reaction, description, analysis, and application. So reaction phase is the step, like these are all the steps. And when I was early simulation educator in my early years, I have a card with me with phrases. And what does it mean? I will show you in a minute. So now go step by step. The first step is the reaction. So allowing them to share their emotion, that how in one word, can you tell me how was the experience or how are you feeling right now? Somebody will say stressed, I'm feeling anxious, I'm feeling happy, so that the emotions will come on the table. It is very important to let their emotion out, because if they become in the same emotional mode, they will not be willing to learn. Then second is the descriptive phase. In descriptive phase, you will summarize the case. It can be either by you or by one of the participants, so that we all come on the same page. For example, the scenario was about a shock scenario. So you will say it loud that this is a 9-month-old child with septic shock that you manage today, who get intubated and get admitted to PICU, so that people do not have a confusion whether it's a septic shock or cardiogenic shock or hypovolemic shock, so that they will be willing to learn and talk about septic shock. That is why it is very, very important to bring up the descriptive phase. Then come the analysis. The analysis about what went well, what are some of the opportunities to get better. It is a very complicated phase, and analysis phase take hours to discuss and get used to, take months and years to get used to it. But frankly speaking, in a nutshell, in one liner, analysis phase is kind of a meat of a debriefing stages or steps, where you will tell or ask them what are the things they did well, where are some of the opportunities to learn, to get better. So this is all about analysis. And at the end, you will summarize, which is summary of the learning points, summary of the cases, summary of the objective. So this is about the summary. There are Pearl's debriefing tools, which is there on the literature, and I'm going to share all of this with each step and with sample phrases, that how will you lead the conversation in each step. So these are all present in the literature, and I will show you a website which has got the debriefing tool, and they're in Arabic language as well, actually. So just give me a second. I'm going to share it. So if you go here to this website, sorry, my email addresses are there. So this is a website which is Debrief to Learn. If you go there, there's a lot of resources about debriefing, the presentation, video recording, and workshops and videos about the debriefing. You can go and listen and learn more about it. But if you go to the Pearl's debriefing tool, it has got all the tool, and you can download the PDF version and pocket card as well. And it has got an Arabic version as well. If I click the Arabic version here, see, it is going to show you the PDF of the Arabic version. I will make it a little bit bigger. Give me 1 second. So this is the Arabic version of all the stages, all the step, and all the phrases that you are going to use. This I'm going to share as soon as I finish my lecture in the WhatsApp. So you have all of this, and you can utilize it whenever you need to use it. With this, I will finish. I know we are at 2:01 and a 1 minute ahead, but I'm happy to take anybody's question. I'm telling you, this is the workshop which is done over 5 days about all this, but we try to capture it in 2 hours, just to give you an idea that when we say facilitation, scenario development, and debriefing, what does these terminologies actually meant by saying when we are taking some of these words and languages. Thank you so much.
Thank you, Dr. Jabin and Dr. Muhammad, for this valuable, clear, informative webinar, and for sharing your expertise with us. We are very thankful for your efforts and for your time. And if anyone has a question, please.
I would like to comment on Asma's comment. Asma, you are very right.
I think everything was clear.
Yeah, I think Asma, you are right. We all are using simulation in our curriculum. We just have to recognize and just make it as a constant effort. So I completely agree that all forms of OSCEs, skills lab, etc., are our form of simulation that you all are doing in some way or other.
And I would say it's always good to look at the INACSL standards and see how are you, like if you, the more you are achieving those standards, the more you are providing high quality education. And then the more you are far, you can work on that, and then you can choose your priority, you know, which areas that you think are more important for your curriculum, which area less important. And don't be paralyzed by, oh, I can't do it unless I have the most expensive mannequin that I can't buy. No, you can do still lots of simulation with very basic mannequins that I'm sure that you have it. I have been into many Egyptian university and I've seen the equipment that you have that was almost 10 years ago. I'm sure things now are much better than where it was. So hopefully you should be able to do that perfectly fine. Yeah.
Yes, exactly. And as I said before, we have started our relationship, and we will continue talking, learning together about more simulation-based education. Any one of you have any question, query, want to do something in terms of research or lecture or session, please reach out to both of us. Thank you.
And we can share our emails in the
Thank you.
WhatsApp group. Yeah.
Yeah, please, Dr. Mohammed, and we are very thankful for your efforts and your time, and we are looking forward to more and more webinars and help from both of you. Thank you very much.
Inshallah,
By
inshallah.
this, we end, inshallah. Thank you for all attendees. Thank you for Dr. Mariam, Dr. Hind, and Dr. Nancy for sharing in preparing this. And many thanks for Dr. Jabin and Dr. Mohammed for their help and their time. Thank you and see you again, inshallah. Thank you very much. Assalamu alaikum.
Alaikum assalam. Take care. Have a wonderful day. Bye-bye.
Bye-bye. Assalamu alaikum.
Bye-bye.